Hi, I'm Dr. Cassi from Vetfolio and the host of Vet2Vet. Today we're talking about infections, pinpointing the culprits and figuring out the best course of treatment. It sounds simple, but as we know, resistant infections that don't respond to empirical treatment can be a major challenge. And our guest today has some incredibly useful information to help us get the most accurate clinical picture and the best results for our patients. Joining me is Dr. Dawn Booth. She's an alumni professor of physiology and pharmacology at Auburn University and the director of a clinical pharmacology laboratory, which offers a therapeutic drug monitoring service to state, national, and international veterinary practices. Thank you for joining us, Dr. Booth.
Well, I am tickled pink to be here, so thank you so much for the invitation.
And we are so glad that you are. So as a general practitioner, treating infections is a common challenge that we face. And doing it in such a way that we're exercising good antibiotic stewardship and getting the best results for our patients is not always as easy as treating the infection sounds. So can you talk to us about what defines a complicated infection?
Well, so the reason for defining it, first of all, is I think we would all agree that you're much more likely going to need to culture if it's a complicated infection. And let me also back up and remind everybody that one of the best ways to become judicious with antimicrobial therapy is to not treat unless you think that you do have an infection. So what constitutes a complicated infection varies, of course, and it's probably easier to say what's not complicated. So, for example, a first-time urinary tract infection or a first-time pyoderma are examples of uncomplicated. Maybe a simple bite wound, but the more the infection progresses, the longer the infection has been there. Certainly an infection that's not responded to previous antimicrobial therapy, but also we step back and look at the patient. So if the patient has been exposed to antibiotics, and I don't mean necessarily this infection, but even a different infection, or if the patient was exposed to comorbidities that will complicate therapy, these are all things that are going to make it more difficult for the antimicrobial regimen that you've chosen to be successful in eradicating that infection in the patient.
It sounds like exactly what you said. It's much easier to name the infections that aren't complicated because most of these really should be treated as complicated infections.
I think many of them increasingly, and just the plug here is given the current state of antimicrobial resistance that we are facing and we're going to continue to face, I think increasingly we need to step back and understand that most of the infections that we are treating probably are complicated one way or the other.
Absolutely, absolutely. And it sounds like more and more our decisions regarding antimicrobial use should really be guided by the results of culture and susceptibility testing. What are some of the considerations in reducing contamination in our culture samples and getting results that are really reflective of the problematic organisms that are causing the infection?
That is such a great question because I can tell you if you do not provide good data to the laboratory, you're not going to get good data back. And if you don't have good data, then automatically you're making your job more difficult. So it begins with how do you collect the sample? And so we know that to reduce contamination, you need to collect the sample using sterile methods. So the cystocentesis for a urinary tract infection, please don't use a clean catch in dogs and cats. If this is a respiratory tract infection, then a bronchoscope or transtracheal wash. If you're dealing with a wound, and they are some of the most difficult ones to get clean samples on, but in that scenario, you want to clean up as much as you can, get rid of the necrotic debris, get rid of anything that's not fresh. If you have to use a swab and understand that swabs are not the ideal, then make sure that you have cleaned the area. And then finally, ideally, get a piece of fresh tissue at the site of active inflammation. But I'm also going to tell you, it doesn't stop there. Your sampling has to be taken care of. And so if it's a urinary tract infection, it needs to be refrigerated from the time you collect it until the laboratory that's going to analyze it receives it. Make sure you're using the proper tools. If you think this is an anaerobic infection, 30 seconds of oxygen will kill an obligate anaerobe. So look at how you're handling that sample. And then finally, pick a lab that knows what they're doing. And that means a veterinary microbiology laboratory, not a human laboratory, and a laboratory that follows the standards of the Clinical Laboratory Standards Institute. They tried very, very hard to take this in vitro methodology and have it apply to the in vivo situation that you're dealing with in your patient.
Absolutely. A lot of considerations that we need to keep in mind. And I started chuckling to myself a little bit when you said not to use a free catch sample for a urinary culture and susceptibility. And I had a professor in vet school who made us all repeat in the lecture hall. She said, repeat after me. I will not use a free catch sample for a culture and susceptibility. So I will say that's something that was drilled in, and I try to make sure I have a clean sample every time I do that.
Well, yay for you.
So what types of testing do these samples undergo when they do reach the lab? Is there a standard method or different methods depending on the sample type or suspected organisms?
Another great question. And probably a veterinary microbiologist would certainly be able to provide more detail. But what they will do is based upon the information that's been provided. And again, I'll encourage your listeners to make sure that they provide as much information as they can, because the microbiologists are going to look at that and they're going to make decisions about how to approach handling this sample based on that. So whether or not a tube dilution procedure that generates an MIC or an agar gel diffusion like Kirby-Bauer is done depends upon the organism that they actually isolate. So the first thing that'll happen is they may do a gram stain. Our lab does that. And it's really nice because it gives us some rapid information so that we can respond maybe immediately. And then they will streak that sample for isolation. If they need to, they'll put it in a special agar. But eventually, when they get it to a point where it's actually isolated, then they will subject it to susceptibility testing according to the protocols that the Clinical Laboratory Standards Institute has promulgated. And I can't emphasize enough how important that is. And the example I'll make is if you're a practice and you do culture and susceptibility testing in your practice, if you're not following these guidelines, then that automatically makes the data that you're generating much more suspect and harder to apply to your patient.
So a lot of considerations in terms of our sample collection and our sample handling, but also, like you said, really making sure that we're providing that information to the lab, because that's going to guide their decisions in terms of getting us the best results. So we really need to, it sounds like, keep a lot of these things in mind when we're trying to get the results for our patient.
And the nice thing about making sure your laboratory follows the standards, the standards will be the same throughout the United States. And so it makes it easier to have confidence that the data that you're getting is the best data that you're going to be able to get.
All these things that I feel like, we all do think about them, but it's so nice to sit down and talk about them and really bring them to front of mind.
Yep.
How is MIC determined? We're talking about submitting these for susceptibility testing. What guidelines should we keep in mind when we get that MIC back and we're trying to interpret it in clinical practice?
And so I mentioned when we looked at the different, you asked about the different methodologies, I actually mentioned tube dilution and MIC. And that's the standard. When we talk about Kirby-Bauer, it actually, the zone diameters, if you are, relate back to MIC. So it makes sense to talk about MIC. So the MIC is the minimum inhibitory concentration. And let's just common sense it. We don't have to get fancy. It's the amount of the drug that it's going to take to inhibit the growth of the organism. Doesn't necessarily kill it, but inhibit the growth of it. And so if we want to know the lowest concentration of a drug that it's going to take to inhibit the organism, then what we need to do is get a standard amount of that organism and expose it to different concentrations of that drug in question. And we want those concentrations to be low enough to tell us, oh boy, this organism is really susceptible. But we also want them to be high enough so that we are approaching the drug concentration you're going to get in your patient. But we don't want them to be any higher than the drug concentration you're going to get in the patient. So the concentrations tested for each drug to determine that MIC are going to vary with the drug, and they're going to depend in part upon the concentrations you're going to get in the patient at the recommended dose. And by the way, it's one of the reasons why we can't really compare compare MICs between drugs because those ranges are based upon the drug concentrations achieved in the patient, and that will vary with each drug.
Absolutely. As our dosages change and, safety profiles for those drugs in vivo, it would make sense that those aren't really translatable amongst the different medications.
Yes, and especially we know that when we give a dose, and just think about your doses of drugs, you give 5 milligrams per kilogram of one drug and 30 milligrams per kilogram of another drug. So automatically you should suspect that the concentrations achieved in the body are going to be different for those drugs, and that's reflected in the ranges of MICs that are tested.
So once we determine that MIC, how does the lab reach a conclusion regarding whether the bacteria is classified as susceptible or resistant or intermediate in terms of susceptibility to a specific drug?
So let's agree that susceptibility means you've got a pretty good chance of that drug being able to treat that infection. So the lab will base that S or IRR on those criteria that I talked about before that Cassi provides. So Cassi spends a lot of time, I shouldn't call them Cassi, the Clinical Laboratory Standards Institute spends a lot of time determining what concentration of drug is going to be too high for this drug to be able to get this organism. And they'll call that the breakpoint MIC. And frequently it's related to the highest concentration you're going to get in the bloodstream. So if the MIC of the isolate that has been collected by the lab turns out to be close to that breakpoint, then you're going to get an I. If it's too close, you're going to get an R. But if that MIC is much lower than that breakpoint, then the lab is going to designate that as S or susceptible, meaning you've got a pretty good chance to get this bug with this drug. The lower that MIC is, or the further away it is from the break point, the greater your chances of therapeutic success. And another way of saying that is the further away that MIC that you get from the lab is from the drug concentration you're going to get in the patient at the recommended dose, again, the more likely your therapeutic success.
Yep. And we've all gotten those results back with a whole bunch of I's and R's on them. So those are no fun.
No, they're a little bit intimidating.
They are, hence why we're here today.
That's right.
What if we're not able to get a sample for culture and susceptibility testing, either because of patient behavior or location of the infection, some other consideration? What if we feel like we're kind of forced to treat empirically?
So that's a really, really tough question to answer, especially increasingly given the environment of resistance that we're dealing with. We've already talked about urinary tract infections and skin. Uncomplicated, you can do a pretty good job guessing, but you need to know two things before you can do a good job treating this infection. One of them is what organism, and the second is, even if I know the organism, do I know the susceptibility of that organism? So, we can go through the textbooks and look, but one thing that has not happened in the United States is we don't have a good monitoring system to help guide us. We do not know what has happened across time as far as the susceptibility patterns of our organisms to drugs. So one of the things I would encourage veterinarians to use is the Target Antimicrobial Handbook app. That app does a pretty good job in gathering information throughout the United States and telling us which organisms are cultured, not necessarily causing infection, but which organisms are cultured from different body sites in the dog and cat. And they give us a feel for the susceptibility of those organisms to the common drugs that we might use. And it can be a very useful app to guide therapy, especially if you feel like you've got a good idea of what might be causing infection.
I couldn't agree more. It's so nice to, in those situations, have something that you can refer to at least give you a guideline.
And don't forget the power of a gram stain, because again, just knowing if you're dealing with a gram positive or gram negative organism, and especially if you can apply it to that app, will help narrow the field a little bit.
Sure. I hadn't thought about that. So we're talking about a gram stain here, but what other considerations should we keep in mind when we're trying to select a drug based on our culture and susceptibility results?
So culture susceptibility is a tool, just like any other tool. It doesn't provide all pieces of information. So I've already told you, just because you've cultured something does not mean it's necessarily causing infection. So stand back and make sure that that culture data makes sense. We can look for viability of growth, extent of growth. I always look, is it light growth, heavy growth, medium growth? And also look for purity. The likelihood that this organism is causing the problem is greater if that's the only organism that you've cultured. But there's a couple of other things I'd like you to, or I'd like our listeners to bear in mind. Remember that you are dealing with a population. And if you understand that this is a large population that is very adept at circumventing anything that you might bring to it, then it helps us respect the approach. For example, all of the colony forming units, each one of them has an MIC for this drug that you're using. There's a population distribution in that infecting population in your patient. Understand that the MIC that you get from the lab is probably the average MIC, the median. So there's going to be much, much higher MICs for that drug in your patient. And that means the more at risk your patient is for therapeutic failure, the more important it is that you use higher doses if it's concentration dependent, or shorter dosing intervals and higher doses if it's time dependent. And one other thing, just because you get an S on a culture report for that isolate does not mean that resistance has not started emerging. If that MIC is getting close to that Cmax, that high drug concentration in your patient, or close to that breakpoint, that means that isolate has already started developing resistance to your drug. And that means you have to be even more careful about designing your dosing regimen.
Such good reminders to use it. Like you said, I think that was a really good way that you put it, to use the culture and susceptibility as a tool. I know so many times I just want to take it as like, oh, look, I got a number. This is what I'm going to use and everything's going to be great. And certainly I've had that experience where you treat and then the next thing that comes back, like you said, is resistance. So such a good reminder to use it as a tool and keep all of those considerations in mind.
And let me add two more points, because the other thing that we forget is the culture data is based upon plasma drug concentrations, but you've got to get it in your patient. So one of the biggest places where we fall down is we neglect to design our dosing regimen to get drug at the site of infection. And sometimes that site is inside the cell, and sometimes that site is protected by biofilm. So understand that you've got to further adjust those doses with those patient factors as well.
Absolutely. Absolutely. The most effective drug is going to be the one that actually makes it into the patient.
That's right. And at the site, actually the one that makes it to the bacteria.
Yes, actually, as patient came out of my mouth, that was the next consideration. Yeah. Well, you can get it into the patient, but it's actually got to make it to where we're trying to get it.
That's exactly right.
Perfect. Perfect. Can you give us a couple of examples where culture and susceptibility testing is maybe underutilized, and explain how having results such as culture and susceptibility would improve case outcomes?
Wow, so that's really, really a difficult question, because of the immediate reaction I want to say is every time,
sure.
And it's always underutilized, but that's not the case. And certainly we can't expect our clients to be willing to do that. But I do think that there are circumstances where it's clear that we should be thinking about it, and that's recurrent infections, infections that have not responded to our initial therapy. But I'm also going to encourage infections where you really can't predict the organism, where you really don't know, because organisms are so different in their responses to drugs. And maybe 3 decades ago, we could reach for a broad spectrum antibiotic and cover all bases, but we can't do that anymore. If you look at the susceptibility of organisms to amoxicillin and clavulanic acid, it's pretty much just a poor to fair drug now. So that makes the practitioner's job much more difficult in trying to predict susceptibility. And certainly life-threatening infections as well. Collect your sample, but then go ahead and treat your patient. I'm going to also answer this in a different way. I'm also going to offer an example of when you don't want a culture. And a good example are patients that have bacteria in their urine, but they don't have clinical signs. Stop looking. You're not going to want to treat those patients anyway. And it's a good example of where ignorance is bliss. So I do think that culture susceptibility testing, if you've done it correctly, really empowers the practitioner, gives the practitioner confidence in being able to build a dosing regimen, picking the right drug, but also designing the dose that is going to increase the likelihood of being able to knock the snot out of that organism. We want to get in quick, hit hard, and then actually get out quick.
Absolutely. Absolutely. That's such a good way to put it, of like, get in there, kill what we're trying to kill, and then get out of there before we create any more resistance.
That's exactly right.
Well, Dr. Booth, thank you so much for joining me today. This has been great. I mean, such a fantastic reminder of something I think that many of us are aware of, but it's so important that, you know, these continual reminders and walking us through the details the way that you have are so important.
Well, I very much enjoyed it.
And thank you to DECRA for sponsoring this edition of Vet2Vet. Check out the Spark section of vetfolio.com for more of our V2V discussions on various topics in veterinary medicine. And remember, if one animal is better off because of you today, it's a great day.